healthcare professional looking for a trusted concussion resource? Then you've come to the right place. From her New York City studios, welcome to Concussion Corner with your host, Dr. Jessica Schwartz.
Welcome to Concussion Corner. My name is Dr. Jessica Schwartz. I'm a physical therapist, brain injury survivor, and founder of Concussion Corner. At Concussion Corner, we bring together the world's leading minds in brain injury rehabilitation to help clinicians serve with compassion, evidence, and community. Today, you'll hear a very special conversation recorded live during our Concussion Corner Academy live Q&A for the Concussion the Patient Rehabilitation Journey Part 2, featuring the one and only Dr. Neera Kapoor, clinical professor of rehabilitation medicine at NYU Grossman School of Medicine, and internationally recognized neuro-optometrist, who I can also call my friend. Dr. Kapoor has lectured across the globe and trained thousands of clinicians in the nuanced art and science of vision rehabilitation after concussion. In this session, we talk about how to identify visual and ocular motor dysfunction, bridge care between disciplines, and understand the functional component of vision that so many concussion patients struggle to describe. So sit back, take a deep breath, and enjoy this candid, educational, and inspiring glimpse inside our Teach One, Serve Many community of Concussion Corner Academy. We're so happy that you're here. Dr. Kapoor, welcome to the Concussion Corner Academy.
Thank you so much for having me, Dr. Schwartz. It's great to be here with you and everyone.
I'm so happy to have you back. And some of this we're actually going to put on the interweb. So I'm so happy to have people meet you outside of our virtual walls, beyond our students. I know you've given over 100+ lectures all over the world because you do what you do so well. So I'm actually really happy to kind of put this out into the world, just like a little amuse-bouche of what we do here at Concussion Corner, to let just people know, get to know you and learn from you, and just to see all that you have to offer. So I'm super stoked to get started.
Thank you so very much. And I like to be an amuse-bouche. It's great. It's fun.
We're true New Yorkers at hand. And I know you have a Canadian background, but I know you're an uptown neighbor of mine. So it's fantastic.
I am, very much so.
So let's get started here, and let's just talk a little bit about what's needed for the rehabilitation provider to really connect to the functional component of the ocular motor system. You know that approximately 2/3 of the brain's pathways are devoted to vision, and about 70% of our sensory environment comes through our eyeballs from a functional standpoint. So I want to really just talk about vision and the concussion being the foundational but often overlooked for the concussion patient. So I'd love to set you up for success there and ask you a few questions if that's good with you.
I would love that. Thank you very much.
So vision is often the missing link. And we know that from what we do here at Concussion Corner Academy and what you do as a neuro-optometrist. With that being said, in your experience, why does visual and ocular motor issues often remain under-recognized in concussion management, even as we continue to evolve our understanding of this injury, both as just really from a full 360-degree healthcare component? We know that you as a neuro-optometrist understand the value of vision. Myself, as someone who has a visual disability secondary to my own brain injury, but what are we missing, or what is often missed in the healthcare community?
Well, first of all, I thank you for the question. In terms of why vision, I think, becomes overlooked or under-recognized regarding concussion is that people often, if a patient is symptomatic, visually symptomatic, they'll refer the person to a primary eye care provider, which quite frankly is very appropriate. I want to make that particularly clear because you want to make sure that everything is sound structurally. By the same token, if everything is sound structurally and they refer the patient back to you and the patient said, everything seems to be fine, but I still feel awful, then naturally the referring provider is going, well, the eye doctor says everything's fine, so I'm not really sure. Maybe everything is fine. Maybe it'll just resolve over time, okay? Which is also an appropriate thought. But I always feel that if the person's vision symptoms, whatever they might be, don't resolve and it's about 3-4 weeks post-event, then it's time to do a more careful assessment. And that's really, I think, a sound approach for any aspect of symptomatology after a concussion. If it's a day or two afterwards and they have a little bit of a mild headache, it doesn't necessarily mean they're falling apart, because every time a person hits their head, it doesn't necessarily mean you're going to have post-concussive symptoms. It really depends how you recover from that particular event. So with that said, my big thing is listen to your patient. If you hear them speaking about intermittent blur, if you hear them speaking about intermittent double vision, if you hear them speaking about light sensitivity, if you hear them say they have difficulty reading or tracking with their eyes, these are fundamental symptoms that a person, if they didn't have them before, some people had them before, but if they didn't have them before and they're reporting them now, it warrants an assessment. And you might say, well, it's hard to find a neuro-optometrist, and that is an issue. It's hard to find optometrists who do specialize in this. And even though the rest of the neuro-rehabilitative community is aware now, much more aware of vision issues, it's taking primary care optometry a little time to catch up with this. But they are, and they will, and we're happy to work with all of our neuro rehab therapists to help our patients. So I hope that helps answer your question. It's a twofold thing. How do I identify it? And then what do we do when we can't find someone to help us with it?
And I think that's where basically what happens for the most part in rehabilitation in general, not just for ocular motor system. But again, I don't want to say this is invisible, but again, for me, my subjective was you do not have the subjective language to express the what and how you feel when you have a brain injury. And so much of that is derived from the ocular motor system and vestibular system. So you don't really understand maybe what double vision is or what a migraine feels like, or really just how your body is not able to negotiate in space, or that you see trails when you're trying to cross a street in New York City when it's changing from light to dark, and transitioning periods from morning and night and vice versa. And I think a lot of that is making sure we're listening to our patients' subjectives, because again, we learn this in medical school, but at the end of the day, it's always said your patients will tell you what's happening. However, if you're not trained, and I say this all the time, if you don't know what you're looking at, you cannot know what you're looking for. And brain injury is so nuanced, and even more nuanced is the vestibular system, and even more nuanced than that is the visual system. And then if that's combined, forget it. And then we add the cervical spine and other things with brain injury in there. But again, it's the functional components. So your patients will give you the functional. Again, my subjective when I was just hit by the car in 2013 was I cannot look somebody in the eye when I'm communicating with them. And for me, I am a happy Labrador that does not stop talking in human speak. And for me, as you know, as a New Yorker, real estate is small here in New York. So going to a restaurant, I could not look at someone at a 2-person table, and I was constantly looking down, which we now know I was diagnosed with a convergence insufficiency. And that continues to be my ocular motor handicap 10 plus years out now at this point. So where I do maintenance and I have to continue to do my work and things like that to keep my eyeballs in check. But subjectively, beyond the blur, because I don't want to say that's a softball, but what are you hearing that's more nuanced subjectively that people might not pick up that's a yellow or red flag in the rehab community?
Certainly. I mean, one of the things that the patients will say is, I can't read. And they don't, and when they say that, sometimes it really throws off a neuro rehab provider. But I always say, because I tell my patients, tell me anything, don't feel hesitant. It's not that I've heard everything, but I'm open to hearing whatever you may be experiencing. Together, we'll figure it out. So when a patient says to me they can't read, I will have paid attention when they were in the front entrance area, the reception area, seeing them initial a bunch of things on the consent form, crossing up something, circling something else. I will say to them, well, it seems that you were able to read and work with a consent form. What do you mean? Do you mean that you can't read the way you used to? And then they usually go, yes, I mean, it takes me 2 hours to read a paragraph with understanding. I have to read it again and again and again and go back and forth and circle something and cross something else out. And I say, that's helpful information. We're going to work on that together. Another thing is sometimes patients will say that I feel something moving in my head. And one of my patients said to me, he said, I'm laughing because it was such a beautiful description. He said, a washing machine, would you? He goes, that's in my head. And I said, okay, that's very helpful. I understand. I said, you're feeling a sensation of movement in your head. He goes, yes, like a washing machine. So patients will tell you all kinds of things, and sometimes they are uncomfortable. So, the major things for me are movement around them. Do they feel the movement in them or around them? Do they feel that they sense a lot of difficulty when they're scrolling on the computer? That's a major thing with the increased usage of digital devices. It may sound like it's nothing, but When you have a lot of text on the screen or multiple targets they have to scroll through on their digital device, that can really throw off our patients. The other thing is looking at a computer screen. That's very challenging. I tend to start with, if you can look at your cell phone and have it dimmer, have it oriented this way, and then move to this way so you have a longer eye movement circuit you have to pass, then move to like a iPad, maybe a tablet of some sort, and then move to a larger computer screen. So you gradually habituate them to handling a larger horizontal eye movement pass. That can be helpful for them in terms of their daily tasks. Many times patients will say, I can read a newspaper article better than I can read a magazine. Why? Because of the columns. And they just fold it over so it's one column at a time. So
I also add the columns 100%. So it's a shorter saccadic movement for them.
correct.
It's less traveling. And I think as rehabilitative people, we understand that when we're looking at short-term goals, like you don't just run a marathon, you have to train in short-term goals. You're going to go be able to walk your mile, then you're going to walk, and then run, and then walk, and then run, and it's going to taper. And we understand pace-graded exposure from a rehabilitative physical movement standpoint. For me also, I had that same issue. And also for folks to understand is also the contrast and the softness, the mattness of a newspaper is important to connect to. In addition to the shininess and contrast of a magazine is also neurologically offensive to the ocular motor patient or vestibular vestibular patient as well. So all things that are subjectives that can be totally missed by folks that aren't understanding the nuances of those in between the care episodes, which every single provider here on our faculty is expert in. And that's what makes you guys so special and so such a gift to the TBI and concussion community and ABI community as well for those reasons. And I think a lot of those subjectives are just often pushed to the side because the providers never heard of them, or B, just doesn't understand how that connects functionally to the neurological or orthopedic systems that may be, impeded or having deficit in the moment. So it's just fantastic to hear from you.
Thank you so much. And, one other thing I wanted to point out is that it's very helpful to start with a task that is in free space rather than a digital task, something where the patient has to actually reach out and touch and connect with it. Why? Because proprioceptive feedback, think about it this way. If a provider external to the patient is performing a near point of convergence and they're slowly moving a target towards the patient, that target is not connected to the patient. The patient really has to cognitively exert a lot of posterior parietal effort to make that mathematical determination of where the target is relative to them. And as it's slowly moving, keep making that constant calculation in order to determine where their eyes need to triangulate. Okay. So if you have a patient where you notice a receded near point of convergence, let's say just for entertainment purposes, it's 5 inches with a recovery at 8 inches, just for entertainment. Have the patient now hold that target and have them start at arm's length and move it towards them on their own. I would bet money in every degree I have that it'll be at least an inch, if not more, closer to them. Why? Because they know where it is. Their arm is connected to them. They now have that proprioceptive feedback and they're able to go, oh, I know exactly where it is and I can follow it in. And that's, I think, a very nice tip to help us understand, is it that the patient really has a true convergence insufficiency, or is it about their dorsolateral prefrontal cortex and parietal lobe not being able to make that instant calculation on the fly as the target is moving? And usually with concussion and traumatic brain injury, it's the latter, not the former.
Yeah. And I think we hear so many things just about not being connected to one's body or self during a brain injury or concussion.
Yes.
And I think the understanding of using weighted vests, heavy balls, weighted bags are really important when doing even just the ocular motor work that may be done in a more neuro-optometric setting like yourself. But I think the carryover is so important. So for me, I remember I actually had to wear a weighted vest. We'll never forget. It was like February 4th, 2014. And really, my vestibular therapist and my OT remember the day my vestibular therapist had to walk me to my OT to Meg at NYU. And Brian was there, and Brian's now in San Diego. And to this day, I hear from Brian on February 4th most years. Happy anniversary, Jeff. Thanks so much. It's good to see you. But we just never forget that day. And for me, we weighted vests. And for me, I just never forgot that. And Becky Bliss actually works with weighted systems as well. And she talks to our students about that. And sometimes you just may have to weight the head to have them start to do some proprioceptive work as well, which is so important for folks to just feel grounded and connected, whether it be vest, blanket, while they're doing the ocular motor vestibular activity. I think is so important to connect to, because again, we want to reconnect the person with their body, with their I am and self.
I totally agree. Also, I think it's important that certainly for the work that I do, I always start with a patient first seated. And when they're seated, I want to make sure that their feet are really flat on the ground and they feel the ground. I want them to be connected with that. I want them to feel stable, steady, and secure. And as they're doing the technique, they are going to become more stimulated, of course, that I'm aware, but I don't want them overstimulated. So once I start to see that they're becoming uncomfortable, and I can usually hear it and feel it from them, it's okay. Now I want you to we're going to stop for a moment. Let's just take a moment. Just close your eyes. Take a deep breath. Let's do it again. In and out. So they bring it all down. I don't want them to be overstimulated, so they come in at like a 1 or 2 on a scale of 1 to 10, and they're at a 9 for 90% of the session. That's not helpful. I was telling one of my patients yesterday, I said, just because I'm capable of running, it doesn't mean that the moment I wake up and stand up that I'll start running, and I'll run for the entire day until I go to sleep. And I said, you should view the same thing with your visual system. You should view the same thing with your vestibular system. You do a bit, you rest a bit. You do a different technique. Switch your techniques up. Make sure that you take a bit of a break. It doesn't have to be an hour break, but take a bit of a break. And as you continue to recover from your concussion, the duration of the task will gradually increase and the duration of the break will increase. But you gotta always be pacing yourself. All of us do, concussion or not.
That's fantastic. And I think to hear those words coming from you are so valuable. And 2 more questions before we have our students come in. And I know Amy B is going to come in. She's in Florida, going to be joining us. But how do you clinically tease apart whether a patient's dizziness or blurred vision is vestibular, visual, or cervical in nature?
Now, a word from our sponsor. Did you know that sport helmets are rated on a 5-star system similar to cars? And the safest helmets have nothing to do with price, brand, or availability? Since 2011, Virginia Tech researchers have been providing unbiased helmet ratings that allow consumers to make informed decisions when purchasing helmets. The helmet ratings are the culmination of over a decade of research identifying which helmets best reduce concussion risk. This work is done as part of Virginia Tech's service mission and is 100% independent of any funding or influence from helmet manufacturers. Our mission at Concussion Corner is to expose you, the listener, to trusted spaces in the concussion arena that translate to clinic next day. Please visit the Virginia Tech Helmet Lab website in our show notes or at bit.ly/Virginia Tech Helmets and spread the word to aid in lowering concussion risk in your community. Thank you for tuning in, and let's begin the show.
That's an excellent question. In terms of when I'm looking at a person's visual vestibular symptomatology when they're presenting, I know I've mentioned this before, but I really think it bears repeating. Observe your patient. Observe them in the reception area if you can before you pick them up. Observe as you're bringing them back to your examination room. You want to look to see what their posture is like. Are they coming in with a couple of bags in each hand, again, for the weighting of them down? Or are they, just a bag over their shoulder and they're just, a little wobbly, but they're okay? Watch and see when they sit down. Are they moving the upper portion of their body to the left or to the right? Or are they free to move their eyes and head as they're looking around the room? Because they will look around the room. They will. They're going to want to look and see what you're doing, what's going on in this room, what's the equipment in this room. People are curious, especially at the first visit. And this is where I get a lot of this information. And then listen to them when they're talking. Listen to where they're talking about their symptoms. If a person is expressing that, when they're in a visually stimulating environment, supermarkets, malls, crowded streets, in the parks, when they're with their kids and there are a bunch of kids around the children. If these are the occasions where they're feeling uncomfortable, and it's not that they're moving their head or neck at that point, but just the movement around them, that's letting me know that there's a visual vestibular aspect of it. And if they're feeling dizzy with that, I'm thinking it's a combo of inner ear and the visual system. Okay. Let's say that they say, well, sometimes I'm dizzy, but it's, often if I'm making quick turns, I'm in the supermarket, I have to quickly look here or there, or looking up or down when I'm cleaning in the house, or when I'm doing errands in the street, or when I'm at the office, bending up to pick up something from a filing cabinet. Then I'm thinking, well, maybe there could be more of a cervicogenic aspect of it. Okay. That could be a big part of it, especially when it's more postural. If it's the kind of thing where and I just had a bout of this, so I can expressly say that I do not like benign paroxysmal positional vertigo. Can I say that? I do not like it. I don't like it one bit. It was a left posterior canal BPPV, and yes, I diagnosed it myself. It was awful. But at any rate, that's of course distinct because I was lying down, flipped my head to the side, and everything was flipping around. That was all inner ear. And there are occasions where patients will have that, and it's not about the movement around them. They could be minding their own business and just everything starts to spin. That's more inner ear. Also, they could have an equilibrium issue, which is also more inner ear, or potentially somatosensory. Listening to the patient, observing the patient, hearing where and when are they symptomatic? Those are pieces that guide me. And by the way, with cervicogenic, when a patient's talking about they usually will express that they do have neck issues. They usually are aware of that, but they may not be aware that there could be a contribution of neck, upper back issues and symptoms with headache and vestibular symptoms, as well as ocular symptoms, oculomotor symptoms. And the reason why cervicogenic affects that is because it's so close to brainstem, right? And that's where our 12 cranial nerves are. And as we know, cranial nerve 3, 4, and 6 directly innervate our eye movement muscles, right? So cranial nerve 4 deals with the superior oblique muscle. Cranial nerve 6 deals with the lateral rectus, and cranial nerve 3 deals with the medial rectus, it deals with superior rectus, it deals with the inferior oblique. Okay, so those are things to sort of be mindful of for you. In the primary modes of action for our oblique muscles, our inferior oblique and superior oblique, are when the eyes are in adducted position, so when they're aimed towards the nose. Okay, that's where you're really going to get the depression action of the superior oblique muscle and the elevation of the inferior oblique. I know it sounds backwards. Well, welcome to vision, darlings. That's kind of how it goes.
I think just to comment there, I think it's important to connect to exactly what you just said, because I think as rehabilitative providers, Dr. Kapoor, I think we understand the physical components of like a concentric and an eccentric motion. And I also, when I'm teaching about the visual component from the oculomotor system, I also talk about degrees of freedom. So we have degrees of freedom similarly in the shoulder and hip. So I kind of bring that into the eyes. So it's actually very comparable from like an eccentric load, with your inferior and superior oblique, so inferior rectus and superior oblique. So I think it actually does cross over once you communicate with us and we get it down.
That's so great. I'm so happy to hear that, because so many people get frustrated about how a superior oblique muscle can be a depressor, but yes, that is its task.
Fantastic. Okay. So, and I think also, just to build upon the interdisciplinary nature of what we do here at Concussion Corner, I think it's important to connect to is that similar to what we do in our kindergarten classrooms, we have little chairs so those feet can be on the floor. You're making sure that your patient's feet are on the floor and they're grounded when you're doing your work. But then I also challenge to make sure that we're understanding what's happening across the aisle, because I want to know what's happening in your office as a neuro-optometrist, as a physical therapist, so that not yours or mine, but our patient can be treated as efficiently as possible, because I may then want to take them out of a seated posture to work on what I want to work on in my clinic or office with the patient. So I may want to put them in a prone on elbows position. I may want to put them in a quadruped position. I may want to put them side lie or supine to start working if they're having cervical spine, deficiencies, and keep them neutral on the table and work on the ceiling or work on the wall so that we can work on some depression, horizontal gaze, and then superior gaze, but keeping a neutral spine. So all of these things are so important and pinnacle to making sure that really I, as a physical therapist, you as a neuro-optometrist, and where our patient is in the middle can really be treated comprehensively and to the highest degrees. It's just so exciting to hear you speak because, again, this is all language that we as rehabilitative providers of our brothers and sisters, PT, OT, speech, neuropsych, athletic trainers all have. And it really just needs to make sure that we communicate when time is such a, valuable thing in healthcare. So just fantastic to hear.
Thank you so much. And I really echo that. I love speaking with vestibular therapists, with PT otherwise too, as well as occupational therapy, speech and language, and neuropsych. Those are the primary providers with whom I work in terms of neuro rehab. They really are so effective, as well as social workers, case managers, because all of us are observing the patient in a slightly different capacity, slightly different insights, depending upon our areas of expertise. And I think that when you get all the little bites together, that's when you start to get the whole. And that's, to me, the most interesting part, because then you see the patient really start to become themselves. And that's what we want.
Fantastic. And one last question before we have Amy come in from Florida. When we've been talking a lot of this course with triaging the patient, well, you just had Dr. Becky Bliss on talking about all things vestibular and movement and so on and so forth, advanced vestibular, I should say. So when multiple systems are involved, what's your process for sequencing care or co-managing patients? Let's just focus on the ocular motor portion for the interest of time, but what's your triage in terms of setting up a session once the patient has already been evaluated? So where are we starting? What's the most important? For us as physical therapists, we really want to try to get some low load cardiovascular activity to try to prime and cross that blood-brain barrier with some just nutrients, get some nutrient and blood through to the frontal lobe, across the blood-brain barrier, maybe bathe that the hippocampus, with some BDNF to kind of prime that system for success. Where are you in terms of where do you want to triage to make sure you're setting your patients up for success for care?
In terms of care from the neuro-optometric standpoint for ocular motility, my first thing is I remind the patient that we are going to be starting slow. You may be feeling it's way too slow for you, but I assure you I would rather start slow and gradually pick up the speed, the velocity of the techniques, and the number of repetitions over time. The first 2 weeks will be super slow. And I let them know also that they are unlikely to see any change in their function for the first 3 weeks. Okay? So this way there's no confusion. When I'm working with them, always starting seated. Initially, typically I start one eye at a time, but it depends upon the patient's presentation. If each eye is functioning relatively similarly, then I will start with both eyes together. I'll work with central fixation, slow and easy. And I want to, if you'll pardon my French, I want a big ass target. I don't want like a little pen tip. No. Look at your fist. Hold your fist in front of you. Look at the heel of your hand. Look at that big ass target. This is not a visual acuity task. And I want it in front of an empty background while the patient's seated. The stars are aligned. The room is dimly lit, but they're comfy. Okay? It's just the two of us. I'm off to the side watching them. I go, just look at the heel of your hand. We're going to count to 5. Here we go. 1, 2, 3, 4, 5. That's great. You doing okay? Yeah, that was all right. All right. Do you think you can do it again? Sure. Great. Do another one. And then I'll just do 2 or 3 reps, nothing crazy. I go, that was fantastic. Let's stretch it out. Take a couple of deep breaths. Just relax, let yourself settle. And then I won't do saccades. Saccades are much harder. Why are saccades harder? Because you're traveling from one target to the next, and the travel is fast. I want steadiness. I want slow movement for the first 2-3 weeks and build up the number of repetitions. So I'm doing fixation, smooth pursuit. I'm not even doing vergence. Too hard. And for smooth pursuit, horizontal,
I'm going to actually show that. I'm going to actually show that video. Yeah,
please do. I want them to have a feel of how slow I'm talking. So here, I know that I'm standing and sitting in front of the patient, but typically I want you to be a little bit to the side of the patient. And you're going to watch as she's following my hand. Watch how slowly I'm moving my hand. This is a very slow, steady movement. You don't want to go too fast. And you want to make sure that you stop moving your hand when the eyes are right at the edge, when there's no more white to go. There is no point in moving your hand beyond that point. Then you're just conducting, which is adorable, but not necessary and not helpful for the patient. So you only want to move your hand as far as the eyes can move, up, down, left, right, and diagonally. Diagonally is important. Why? Because we use that in our day-to-day life so often. But again, it's a slow, easy movement. And to me, that's so particularly important. And that slow, easy movement also applies when you're doing near point of convergence. Here, we're slowly going to be moving the target. Again, look at how slowly I'm moving that. See? You see that? Nice and easy. And I'm watching to make sure that both eyes are staying on the target, right? And I'm watching and listening. I want to watch to see if she loses alignment on the target and if that coincides with when she says, I see two now. And then you're going to see I'm going to slowly stop because now she's starting to see double. I'm confirming with her, and then I'm again slowly moving it out. Why? What am I looking for now? The recovery when she regains fusion. It's insufficient, no pun intended, but it's insufficient to just look at the break. Because a person can see double at 1 inch from them or right to their nose, but maybe they'll recover at 5-6 inches from them. That may be why they're symptomatic. Okay? So the recovery is just as important as the break. And that really bears repetition. The recovery is just as important as the break.
And I think that's where a lot of our colleagues in PT and OT and even our physician colleagues that may be measuring this to do some screening often is missed to measure the break. So the recovery, excuse me. Recovery. So again, just thank you so much for doing this. Thank you so much for coming on. The handouts were wonderful. The videos are wonderful. Where can folks find you in 2026? Are you doing any lectures? Or I know we have a big journal coming out as well.
I do have a big journal coming out as well. But first, in terms of lectures, I'm speaking about stroke and actually stroke and vertigo, and that's at Northwell Health on November 13th. I'm also going to be speaking at Pianis on March 6th, and that's, if my recollection is correct, that should be in White Plains, New York. So looking forward to that. I'm going to be lecturing to some residents in February. I'm going to be lecturing hopefully at some point in India in April of 2026, barring any major mishaps. We'll see how things go. The mishaps being on my end, not on India's end. India's fantastic, and a shout out to all my colleagues in India. But another wonderful thing is there's an interesting journal for which I'm guest editor of a special issue, and that's the International Journal of Emergency Medicine. They're having a special collection talking about emergency medicine trends for managing mild traumatic brain injury, which is concussion. And we're getting our last few manuscripts approved, so we're anticipating that should be up and running for the new year and available to all via open access. And I'll share that information with Dr. Schwartz as soon as I have that, which should be in the next month or two.
Fantastic. Well, thank you so much for coming on. And we wish you all the best. And just thank you for serving all of these patients with such grace and care, and just really understanding those in between the care episodes of concussions. So you've just served our community so well. So it's just been a pleasure.
Thank you so much. Thank you so much, Dr. Schwartz.
What an incredible discussion with Dr. Neera Kapoor. Her clarity, humility, and deep compassion reminds us of why interdisciplinary collaboration changes lives. If you'd like to continue learning from Dr. Kapoor, she'll be presenting on stroke and vertigo at Northwell Health on November 13th, and again at Brain Injury Association of New York State, also known as Pianis, on March 6th in 2026 in White Plains, New York. She's also guest editing a special open access issue of the International Journal of Emergency Medicine on mild traumatic brain injury, launching in early 2026. To study directly with her, join us inside the Concussion Corner Academy walls for Concussion, the Patient Rehabilitation Journey Part 2, where you can meet Dr. Kapoor live during our rolling faculty Q&A sessions and earn 30 hours of CE alongside clinicians from all around the world. If you found this episode helpful, please like, subscribe, and share Concussion Corner Podcast with a colleague. Every download helps us reach more providers and patients who deserve compassionate, evidence-based, informed concussion care. Thank you for being a part of our Teach One Serve Many community. We are so happy that you got to take a little glimpse of inside our virtual walls and what it's like to meet and get to know our faculty. Until next time, stay curious and take care.
Thank you for listening to the Concussion Corner, hosted by Dr. Jessica Schwartz. The information in this podcast is for entertainment purposes only and not to be used as personal medical advice. Don't forget to follow us on social media on Facebook, Instagram, Twitter, and YouTube at Concussion Corner.